Mississippi's public mental health system serves individuals with mental illness, intellectual and developmental disabilities, and alcohol and substance abuse problems, delivered through three major components: programs operated by the Department of Mental Health, 14 regional community mental health centers, and nonprofit and other community service providers. The mission of the Mississippi Department of Mental Health is to support a better tomorrow by making a difference in the lives of Mississippians with mental illness, substance abuse problems, and intellectual and developmental disabilities, one person at a time. Inspiring hope, helping individuals on their road to recovery, and improving resiliency are key factors to the success of the people we serve. We envision a better tomorrow where the lives of Mississippians are enriched through a public mental health system that promotes excellence in the provision of services and supports. A better tomorrow will exist when all Mississippians have equal access to quality mental health care, services, and supports in their communities, when people actively participate in designing services, where the stigma of mental illness, intellectual and developmental disabilities, substance abuse, and dementia has disappeared, when research, outcome measures, and technology are routinely utilized to enhance prevention, care, services, and supports. The governing body of the Mississippi Department of Mental Health is a board comprised of 9 members appointed by the Governor of Mississippi and confirmed by the State Senate. Members' terms are staggered to ensure continuity of quality of care and professional oversight of services. The central office of the Mississippi Department of Mental Health is comprised of an executive director, Ms. Diana Mikula, a deputy director, the Bureau of Administration, the Bureau of Alcohol and Drug Services, the Bureau of Community Services, the Bureau of Intellectual and Developmental Disabilities, the Bureau of Mental Health, the Bureau of Outreach, Planning, and Development. The Mississippi Department of Mental Health consists of 6 behavioral health programs. Mississippi State Hospital, which is located in Whitfield and provides residential services for mental health, substance use, and Alzheimer's disease and other dementia. Mississippi State Hospital is Joint Commission accredited. North Mississippi State Hospital is located in Tupelo and provides acute inpatient services for adult men and women with serious mental illness. South Mississippi State Hospital is located in Purvis and provides acute inpatient services for men and women with serious mental illness. East Mississippi State Hospital is located in Meridian and provides residential and community services for mental health, substance use, Alzheimer's, and other dementia. Central Mississippi Residential Center is located in Newton and provides behavioral health services in a community setting, minimizing the need for hospitalization. The Specialized Treatment Facility is an adolescent behavioral health residential treatment program. Residents are between 13 and 18 years of age who have been civilly committed or transferred within the Department of Mental Health. Priority placements are given to adolescents who have come in contact with the legal system. DMH is responsible for the development and implementation of services to meet the needs of individuals with intellectual and developmental disabilities. This public service delivery system is comprised of 5 state-operated comprehensive programs, a state-operated program for youth who require specialized treatment, the 14 regional community mental health and IDD centers, and other nonprofit community agencies and organizations that provide community services. Community and residential services are offered at Hudspeth Regional Center in Whitfield, Boswell Regional Center in Magee, Ellisville State School in Ellisville, North Mississippi Regional Center in Oxford, South Mississippi Regional Center in Long Beach, and the Mississippi Adolescent Center in Brookhaven. The second part of the public mental health system are the 14 regional community mental health centers, which operate under supervision of regional commissions appointed by county boards of supervisors. These centers are the primary service providers of outpatient community-based services in the state. DMH certifies, monitors, and provides technical assistance to the CMHCs. These agencies and organizations make up a smaller part of the service system. These programs are certified by DMH and may also receive funding to provide community-based services. The third part of the public mental health system is made up of nonprofits and other community providers. Many of these nonprofit agencies also receive additional funding from other sources. Currently, services are provided through these nonprofit agencies, including community-based alcohol drug services, community services for people with intellectual and developmental disabilities, and community services for children with mental illness or emotional problems. The entire public mental health system has common goals. These goals include supporting the evolution of mental health services, educating the public to help erase the stigma of mental health, bringing more services to the community, and focusing on recovery and community integration. We must all work together to accomplish these goals and ensure a better tomorrow for the public mental health system. We want to support people as they restore, rebuild, and reclaim control of their lives by increasing their resilience and focusing on their strengths. We want everyone to have choices. We want people to be able to live in their community. We want the people we serve to define their own life goals and design a unique path towards those goals. We want to give people hope. Hope is the catalyst of the recovery process. Hope is what makes each of us get out of bed in the morning and strive for a better day. Hope is what keeps us moving forward. As leaders in recovery, I want you to want these same things. My hope is that we can all work together to make a difference in our state. To better understand the concept of individual and family participation, it must be considered within the larger recovery movement. Traditionally, within a medical model of mental health care, recovery was defined as an absence of symptoms. Proponents of the recovery movement described an alternative perspective, where true recovery is reached when individuals take control of their lives, make their own decisions, and find fulfillment in their societal role. When recovery is defined in this manner, full individual and family participation must be recognized as an essential component of the development and the delivery of mental health services. Recovery is based on the involvement of consumers, peers, and their family members. States must work to support and help strengthen existing community, family, consumer networks, recovery organizations, and community peer support and advocacy organizations in expanding self-advocacy, self-help programs, support networks, and recovery support services. There are multiple pathways to recovery based on an individual's strengths and resiliencies, as well as his or her needs, preferences, experiences, and cultural background in all of its diverse representations. We are committed to our efforts to actively engage individuals and families in planning, evaluating, and implementing mental health services. DMH believes people are the focus of the public mental health system. We respect the dignity of each person and value participation in the design, choice, and provision of services to meet their unique needs. The care we provide must be person-centered and individualized. As healthcare providers, we respect the dignity of each person and value their participation in the design, choice, and provision of services to meet their unique needs. Efforts to actively engage individuals and families in developing, implementing, and monitoring the state's public mental health system include personal level, planning of services, evaluation of services, and implementation of services. The personal level is participating in your own care as a person receiving services with service providers. Self-directed means that you lead, control, exercise choice over, and determine your own path of recovery through independence and control of resources to achieve a self-determined life. By definition, the recovery process must be self-directed by the person who defines his or her own life goals and designs a unique path towards those goals. And the planning of services level, individuals and family members have an opportunity for meaningful participation on planning councils, task forces, and work groups on a state, local, and national level. DMH sponsors mental health planning councils and other task force work groups and committees as avenues to address issues and needs regarding the public mental health system. Based on the 2014 Advisory Council survey, individuals and family members are in leadership positions within our state planning councils. Specifically, the chairperson of 2 of the state's 4 planning councils is either a family member or a person receiving services. As a result of the survey, DMH hosted a Leadership Academy in 2015 to offer individualized training for people to focus on how to expand their current role and be able to serve on task force and work groups. In the evaluation of services level, individuals and family members have an opportunity to participate on personal outcome measure interviews using the Council on Quality Leadership's personal outcome measures. The personal outcome measure interviews provide an opportunity for individuals and family members through a guided conversation to evaluate quality of life. Individuals and family members on a local level are involved in individual and family satisfaction surveys. Instead of looking at the quality of how services are being delivered, personal outcome measures look at whether the services and supports are having the desired results or outcomes that matter to the person. With POM interviews, focus is placed on listening. When we listen, we learn what people want. When we listen, we discover that people want to be participants in their community. They want to be empowered to make choices and participate in self-directed care. They want to be connected to family and friends. These are the same things we all want in life. In the implementation of services level, consumers and family members are employed as certified peer support specialists and our peer support specialist. A certified peer support specialist, or CPSS, is a family member or an individual who is self-identified as having received or is presently receiving behavioral health services. Additionally, a CPSS has successfully completed formal training recognized by the Mississippi Department of Mental Health and is employed by a DMH certified provider. These individuals use their lived experience in combination with skills training to support peers and family members with similar experiences. CPSSs support their peers both individually and in groups. Under general supervision, a CPSS performs a wide range of tasks to help people regain control of their lives and their recovery and resiliency journey. They provide varying supports, some of which may be offered by others in the public mental health system, but CPSSs contribute something unique. They are living proof that recovery is possible. CPSSs share their lived experiences and are willing to share their stories to benefit others. The role CPSSs take to assist individuals to regain control of their lives and their own recovery journey is vital. Inspiring hope, helping individuals on the road to recovery, and improving resiliency are key factors to the success of the people we serve. DMH sponsors meetings with CPSSs to discuss the role of peer support and barriers to provision of peer support services within the public mental health system. Peer support specialists are able to contribute something unique. They are the living proof that recovery is possible, which provides strength and stability to individuals as they travel sometimes the bumpy road of recovery. DMH truly believes peer support specialists are essential to the successful community integration and to the transformation to a person-centered and recovery-oriented system of care. We must all work together to accomplish the goals and ensure a better tomorrow for the public mental health system and the people we serve. We hope we have conveyed how much your involvement and role in the future of the public mental health system truly means to our agency. While DMH's mission and vision are vital, they mean little apart from the story that explains why we are doing it in the first place. That story is you, your family members, your friends, my family members, my friends, everyone that we know that has been touched by a mental illness, intellectual and developmental disability, or substance use problem. We all have a story, but your personal story is why your leadership is needed to help improve the lives of others.
For many years, after I was diagnosed, when I first woke up in the morning, my first thought was, I have mental illness. My life is over. I felt flawed. I knew it was flawed, frankly. And I felt that my life was going absolutely nowhere. And I was a little bit angry. This is not what I wanted to do when I became an adult, was to sit back and suffer with the mental illness. I don't have that thought anymore, and I can't remember the last time I woke up with that thought. My life has been reclaimed.
Recovery, to me, is something that a person has to do when they have been through a mental illness or when they have been through drug use. Recovery for some people is, I equate it to using a ladder. Some people can use this ladder by themselves. For some people, that's okay. But some people have to have a spotter when they use your ladder.
Having mental illness, it was a tough road. It's been tough for anybody that has it. There were so many hospitalizations in and out. The stigma of people laughing at me and telling me I was a little crazy, or joking to me that the hospital has swinging doors on it for you. All these comments just really helped to hinder my recovery. But when I was able to finally move into recovery and begin life anew, which is what it felt like, all this began to fade. Being in recovery for me means that I have to understand what my symptoms are to be able to spot them and to do something about them as soon as possible. It means I understand my triggers, but it also means I continue to work on those symptoms and those triggers to totally move forward in my day and not let these things rule me. I can't remember, as I said, the first time I woke up, or the last time I woke up with, I have mental illness. That's gone away. Part of the reason, though, that I work as a peer support specialist is to be able to talk to others about this. I can't help someone else if I'm not willing to be open about what this was like so that they understand that I understand.
Working with individuals as a peer support specialist, you see them at their best, you see them at their worst, but at the same time, they're also seeing you at your worst and at your best, because a lot of the youth that I work with, they think I'm helping them, but when I really sit down at the end of the day and think about it, the youth are actually helping me.
Peer support turns out to be an awesome thing to have been developed. If you happen to be a person that has gone through and survived an issue, a serious issue or a not so serious issue, it helps so much to have a person by your side that can actually walk you through the steps, walk you through the paces to help you develop, help you achieve your goal that you're trying to do. If you happen to have had a child who has gone through being diagnosed and you have such a hard time understanding what's going on, a peer support that has raised a child that has been through the same thing can help you understand that it's going to be okay. You can do this. Just be there when they need you. Be there to help take you to different appointments, to be there as an advocate to speak for them when they cannot speak for themselves.
It's a totally different feeling completely to be able to work with someone who has the same diagnosis or a diagnosis period. I often, as I said, work with my peers on their symptoms, their triggers. Let's talk about it. Let's be open. I'm so much of an advocate, I think, though, for these individuals. I tend to point out to them that mental illness is something we have. It's not who we are as a person. I'm so much more as a person than just someone with a diagnosis of mental illness. And I ask each of those individuals, what else are you besides having a mental illness? Are you a mother? Are you a sister? Are you a daughter? Let's talk about the other things in life that are good. Let's talk about our strengths, things that make us strong, and we need to focus on those strengths. Stigma often is one of the biggest barriers for people. They're afraid to talk about it. I can't be afraid to talk about it if I'm going to help someone else.
Most of the kids that I work with, they always tell me, Mr. Jonathan, you don't understand. You don't deal with what we deal with. And I just let them know I dealt with the same thing that they actually dealt with 15 or 16 years earlier. It's just I was blessed to have a strong support system at home, and a lot of them don't have that. But a lot of people kind of push them to the side because of the environment that they're in and the activities that they've been involved in. And I just try to let them know that broken crayons still color. I mean, it's still good in everybody. You just have to find that good in them and let them know that they are worth fighting for.